The Self-Care Learning and Discovery Series is back, and it's bigger and bolder than ever. This is the premier self-care event of the year, bringing together self-care enthusiasts of all backgrounds and disciplines from around the world. The World Health Organization defines self-care as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of a healthcare provider. We also know that self-care means different things to different people. What does self-care mean to you? You'll have ample opportunity to reflect on this question during the Discovery Series, with more than 20 interactive virtual sessions organized by self-care experts worldwide. The Discovery Series will elevate cutting-edge research, programming, and advocacy insights across a wide variety of self-care topics, and we encourage you to attend as many sessions as possible, especially on topics that may be new to you. The Self-Care Learning and Discovery Series, a core activity of the Self-Care Trailblazer Group, is organized by the White Ribbon Alliance in partnership with co-sponsor organizations and esteemed steering committee members. We also want to thank all our session organizers and presenters who have voluntarily dedicated their time to curate this event with us. We are pleased to share that every session will offer live, simultaneous interpretation in French, Spanish, and English. To access the interpretation, simply navigate to your meeting controls located at the bottom of your screen. Click on the globe icon labeled Interpretation and select the language you'd like to hear. Joining from your phone, tap on the ellipses to find the interpretation feature and then select your language. Please note, you can switch languages at any time throughout the presentation. The session is now about to begin. Don't forget, whether you're working to influence policies or programs, advance universal health coverage, or improve your own self-care, we hope that you will take the learnings from today's discussion and apply it to your own work. To that end, we invite you to continue the conversation and take action with us by becoming a member of the Self-Care Trailblazer Group. So get curious, jump in, and share your ideas and insights with us. We look forward to advancing self-care together.
Thank you. Welcome, everybody. Good morning, good afternoon, and good evening from wherever in the world you are joining us today. We are really excited that you have opted to join this flash session this morning that's entitled More Places and Spaces, Supporting Self-Care Promoters in Facilities, Pharmacies, and Communities. We have an exciting and rapid 90-minute session this morning, and I'm honored to share the virtual stage with an incredible set of speakers from across the world who are bringing together diverse perspectives on self-care. Before we get there, I should probably introduce myself. My name is Bhavya Gowda, and I'm a Senior Market Access and Commercialization Lead with PATH's Diagnostics Program. Before I stepped into my current role on the diagnostics team, I spent a portion of the previous 6 years supporting a project that was related to access to DMPA-SC and self-injection. So the project and that work really sparked my interest in the self-care space, and my professional interests have continued to grow and expand, including in areas like self-testing. I truly believe that self-care can be practiced anywhere, especially when different cadres and channels are equipped to support people to manage their own health, which our speakers and our presenters are going to discuss through their presentations. If we could go to the next slide with the agenda. So we have a total of 7 flash presentations. Each presentation is about 6 minutes, so this is going to be really snappy. After the first 4 presentations, we're going to stop for a brief Q&A session, and then we're going to have a second Q&A session at the end to cover the final 3 presentations. Before we dive in, I wanted to remind everyone of a couple of housekeeping guidelines. The video at the beginning mentioned how you all can access simultaneous translation, which you should be able to do at the bottom of your screen. We have also asked presenters to remember to speak a little slowly, given the simultaneous translation. For our participants, thank you for joining us today. We're going to ask that you stay on mute during the presentations. If you accidentally come off mute, our Zoom hosts are going to remute you. We want to make sure that it's not being disruptive to our presenters today. I would also like to encourage you all to drop questions into the Zoom chat during the presentations. I'm going to collate those, and I will do my best to address them during the 2 Q&A sessions. The last thing that I would say is if you're in a position to do so, feel free to come off mute. Not come off mute. Feel free to come off video. You all have probably provided and given Zoom presentations over the last 3+ years. And whenever I'm presenting, it's always nice to see a couple of faces as opposed to just seeing a bunch of black boxes and names. So if you feel encouraged or would like to do so, feel free to turn your videos on at any point during this session. All right, so that's our plan for the next 90 minutes. And with that, I'm going to go ahead and introduce our first speaker. Our first speaker today is Fauzia Tariq. Fauzia Tariq is a lifelong data nerd with a passion for helping projects to nimbly use their data and learnings to adapt and make decisions that maximize outcomes and impact. Over the years, she has supported ministries of health to develop monitoring and evaluation plans, integrate and streamline metrics, and create an enabling environment for active data use. Fauzia is currently the Monitoring, Evaluation, and Learning Advisor for the Delivering Innovation and Self-Care Project, or DISC, at PSI, where she is part of the team dedicated to supporting women through their contraceptive self-care journey. With that, Fauzia, over to you.
Thanks so much, Pavia. Good morning, good afternoon, good evening, everyone. So nice to be here. Today, I'd like to share with you the power of empathy in supporting women to self-inject on behalf of the Delivering Innovation and Self-Care, or DISC project. DISC's vision is to bend the curve on the uptake of self-injectable contraceptive through ensuring that all women who choose this method have frictionless access. Next slide, please. So the problem that we focused on was the leaky bucket that was caused by a low voluntary adoption rate of self-injectable DMPA-SC following training. According to research conducted by PATH in Uganda, 4 out of 5 women cited fear of the needle as their main reason for not self-injecting. This led to a number of issues, including system inefficiencies around investments in demand creation and provider training, reduced value proposition for providers who felt that self-inject training was time-intensive, and a reduced potential for women to truly experience power and agency in their SRH care. Next slide, please. Through an iterative and adaptive learning and implementation process, DISC developed a complex intervention that combines community activation and empathy-based provider trainings and supports them with the foundational investments in commodity supply, supported supervision, and data reporting. The empathy-based training curriculum focuses on increasing providers' confidence and capacity to effectively coach women to overcome their fears of pain and lack of self-efficacy to successfully initiate self-injection. Using an approach grounded in behavior change, the didactic training is reinforced with role plays, job aids, live practicums, and a follow-up supportive supervision. Next slide, please. DISC conducted an evaluation of the empathy training intervention from June 2022 through March 2023 in Nigeria. 36 facilities were selected across 3 states, Niger, Lagos, and Oyo. The selected facilities were offering DMPA-SC services, but had very low SI uptake. They had not previously received DISC training or support, and they were located in subgeographies where the DISC project was not engaged in demand creation activities. So we wanted to maintain as much independence as possible. The evaluation was set up in 4 distinct 3-month-long phases. Phase 1 measured baseline service delivery pre-intervention, so sort of what the service delivery looked like, FP uptake looked like before DISC intervened. During phase 2, DISC strengthened provider reporting capacity to determine if self-inject services were being offered but not routinely reported. And during phase 3, DISC launched the full-scale empathy training intervention, which included community mobilization, provider training, supply management, and data reporting supports, as well as follow-up supportive supervision to really reinforce the behavior change. During phase 4, we maintained the intervention through routine, although less intensive supportive supervision and community mobilization activities, so slowly weaning the full scale off. During each phase, we looked at routine service statistic data and used it to monitor trends in FP service delivery with a specific focus on DMPA-SC, PA, and SI service provision. We looked at the entire method mix also to monitor for informed choice. An interrupted time series analysis was used to measure differences in the main level, so immediate effects, and the trend, the longer term effects between each of the phases and to gauge the effects of the DISC intervention. Next slide, please. And here we have some of our results. Routine service delivery data shows that substantial increases in both the volume of SI visits and the proportion of DMPA-SC that is self-injected across all 36 evaluation sites. These increases coincide with the implementation of DISC's empathy training intervention package during phase 3. So that sort of big jump that you see in each of these graphs, the trainings occurred in the first week of October 2022, the DISC intervention trainings. And apologies, I didn't point out that we did the data strengthening during late June, early July of 2022. The data also show that strengthening provider data reporting capacity alone did not have a significant impact on the reported uptake of self-injectable DMPA-SC. Next slide, please. The interrupted time series analysis shows that the empathy training intervention is associated with a 52 percentage point increase in the proportion of DMPA-SC that is self-injected and a 42 percentage point increase in the proportion of all injectable provision that is self-injected. So we're seeing the shifts that we were targeting. So shifts within injectables and shifts within the provision of DMPA-SC itself. Next slide, please. Empathy training was also associated with a mean increase of 27 FP visits per facility per month, which was sustained over time and did not affect LARC service delivery at evaluation sites. Data also show that the method mix is shifting within short-term methods, with the greatest shifts within injectables. So again, monitoring for that informed choice component and making sure that we aren't unduly influencing the FP method mix. Next slide, please, and final slide. So DISC has done a lot of learning over the course of its intervention, and the empathy training intervention is driving similar shifts in uptake of self-injectable DMPA-SC across all of our markets, so Nigeria, Uganda, and Malawi. And through direct trainings and catalytic work with MOHs and some fantastic partners, DISC is working to really bend the curve on self-injectable contraception and really support women within their self-care journeys. Our research and learning stem from facility level and national health systems data collection, as well as provider and client exit interviews. And we have lots of learnings to share. So if you'd like more information, please reach out. We've got our website and our email address listed here. And that's all from us. Thank you so much.
Thank you so much, Fauzia, for kicking us off with our first presentation. Some really, really interesting results that you all generated, and it's amazing what a little bit of empathy can actually go a really long way in terms of increasing uptake. So, thank you so much for sharing those learnings with us. If you have any questions for Fauzia, please drop them into the chat, and I will address them during the Q&A session. Friendly reminder to our presenters to please remember to speak slowly to help our translators that are translating live in real time. And with that, I'd like to introduce our next speaker. Let me put this up. One moment. So our next speaker is Ijeoma Egwatu, who's an activist and currently with Generation Initiative for Women and Youth Network as Director of Data Innovation and Communications. With more than 10 years of experience at the GIWYN, focusing on sexual reproductive health and rights of young people. Ijeoma is one of the driving forces in the establishment of her organization's reproductive health hotline. She's also a research site coordinator for IBIS Reproductive Health in partnership with her organization. She has co-authored journal articles and has participated and presented in conferences, seminars, workshops on SRHR nationally and internationally. She attended Madonna University in Nigeria, where she obtained a Bachelor of Science degree in So Ijeoma, over to you.
Thank you so much, Beva. I'm happy to be here today. Okay, so hi everyone. Greetings from wherever you joined from. Like Beva said, my name is Ijeoma Egwatu. I'm the Director of Data Innovation and Communications at Generation Initiative for Women and Youth Network, which you can call GWYN. So today, I'll be talking about the work which has been done by GWYN in Nigeria, La Revuelta in Argentina, and Samsara in Indonesia, in partnership with IBIS Reproductive Health to expand access to the safe abortion and accompaniment model of support. So next slide, please. So self-managed abortion, self-managed medication abortion is not new. In fact, it was pregnant people in Brazil that discovered the use of misoprostol to terminate pregnancies. So given the restrictions on abortion globally, accompaniment groups and safe abortion hotlines around the world have emerged to ensure that all people, regardless of legal settings, are able to access information and support on self-managed medication abortion. So these groups have been in place for decades, ensuring access to safe abortion methods in context where there is no access within the formal healthcare sector. So the Miss Rosie hotline, which has been operated by GWYN since 2014, is one of the 50 and more feminist community-based hotlines globally, and one of the best in Africa. So people in Nigeria who call Miss Rosie hotline receive information and support on how to self-manage their abortion using either of the two WHO recommended regimens for abortion. Next slide, please. So over the years, we have partnered with IBIS Reproductive Health, a nonprofit research organization, as well as other accompaniment groups like Revuelta and Samsara, to conduct research on the experiences of people who self-managed with support from hotlines and accompaniment groups. So together, we have published several papers documenting the safety and effectiveness of this model of care, which has contributed to the World Health Organization shifting their guidelines to fully recognize self-managed abortion as a safe and effective, So one thing that we have learned from Safe Study was that even though people were self-managing, they interacted with formal healthcare providers, either to obtain medications, obtain ultrasounds, or pregnancy tests. They seek follow-up care to confirm completion. So however, many reported needing to go to multiple pharmacies to get enough misoprostol for their abortion. And many reported not telling a provider that they had had an abortion for fear of criminalization or stigma. Next slide, please. So even though we as accompaniment groups, we are able to support people in self-managing their abortion, given the role that different healthcare workers play in self-managed processes, we sought to build the capacity of pharmacies, community health workers, midwives, and other providers to improve the overall quality of self-managed abortion care. So over the past 2 years, each of our organizations have been conducting several interventions For example, La Revuelta has been training medical students in Argentina and social workers on the abortion law and abortion provision. Samsara has been training midwives and community health workers in rural areas of Indonesia on the same abortion provision as well. And we at GWINE have been training pharmacies, community health workers, and peer educators on abortion provision. So next slide, please. So overall, we found that these trainings have been highly effective at improving the knowledge and capacity of providers in supporting people in their medication abortion process. So as you can see on this graph, there was a significant increase in knowledge of medical abortion protocols after participating in trainings. So one important thing learned from in-depth interviews with participants was that pharmacists and community health workers wanted to help people terminate their pregnancies. They just lacked the knowledge or confidence on how to appropriately counsel them. So prior to the training, many were not selling abortion medications, not because they were against abortion, but because they didn't know how to counsel. So participating in the trainings helps them gain the knowledge, the skills, and importantly, confidence to be able to support those in their community access safe abortion, to access safe methods of abortion. Next slide, please. So speaking about the next steps, in our experience at GWINE, we've seen that pharmacists are at the forefront of self-care, and working closely with them can improve access and quality of care. So we and La Revuelta and Samsara are continuing to work with different cadres of providers in our context, so they are adequately trained to help and support those in their communities. So we have feminist accompaniment groups and grassroots organizations that have supported people in self-managing their abortion with medication safely and effectively for decades. And now we are also bringing our feminist model of care to other providers who may interact with people who are self-managing. So we know that additional resources and support are needed so that we in the community can continue to share our expertise and further expand this model of care. So that's all I have to say for now. Thank you so much, everyone, for listening. And please feel free to reach out if you have any questions. Thank you so much.
Thanks so much, Gioma. That was really, really interesting. And even with both of these presentations, it's really clear to see the critical role that healthcare providers play and the importance of good counseling and training, especially in the case of the self-managed medication abortion, and how much knowledge and awareness of providers is a critical piece of providing care for access to services. So thank you so much for that. And please keep the questions coming through the chat. I am recording them. We are going to move on to our next speaker. Juliet Nabunje is a Ugandan with a BSN and MPH who is working with the International Rescue Committee's Uganda Country Program as a senior research and innovation officer on the She Cares project that the IRC is implementing in 2 refugee settlements. Her passion is research and projects focused on improving girls' and women's health. Juliet, over to you.
Thank you so much, Chair. And my regards to all of you who have joined in. I'm presenting a research study on self-managed contraception availability and readiness of self-care promoters in the Bidibidi and Parabek refugee settlements. Next slide. Flash the next slide, please.
Apologies, 1 second. My colleague who is sharing her screen, her internet just went out. 1 moment, let me pull up your slides.
Okay. Okay, so thank you so much. International Rescue Committee, in collaboration with Accord Uganda, World Debt and the Ministry of Health are planning to implement the SheCares project in refugee settlements of Bidibidi and Lamo to improve uptake of self-managed contraception among the adolescent girls and young women. So with all the innovations we are preparing, we hope there will be an increased demand of self-managed products. And therefore, we carried out a survey to assess the readiness and availability of the self-care products in the settlement and the ability of the self-care promoters to offer the services. I'm Juliet Nabunje, and these are my co-authors. Next slide, please. Okay, so in Uganda, the rate of teenage pregnancies has remained high at 25%, despite the several interventions that have been put in place, and exponentially increased during the COVID-19 pandemic. And in refugee settlements, the rate is even higher due to the increased risks of sexual violence, transactional sex, and we also have the facility-based barriers like language, distance, privacy concerns, and so on. So the rate of teenage pregnancy in Parabek is at 31%, and in Bidibidi, during the period of 6 months, 286 teenage pregnancies were recorded in just that short time. And therefore, self-managed contraception has the potential to address these gaps in facility-based care and increase clients' empowerment. So to inform the new programming, it is important to leverage and improve existing self-managed contraception entry points in the community and health systems and identify barriers to overcome for future programming. Next slide. So how did we do this? We used a standardized checklist to assess availability and readiness of self-care promoters to provide the services. The outcome of the analysis included availability of self-managed contraceptives, and then availability of the supplies, the job aids, providers' practices, and the cost of the self-managed commodities. So we did this in 60 facilities located within the 5 zones of Bidibidi and 30 facilities located in Parabek refugee settlements. Next slide. Okay, and here are the results. So the first graph shows categories of the facilities that were assessed. So as we can see, the blue indicates the government facilities, the orange indicates the private facilities, and the gray indicates the private facilities. So we are seeing that in both settlements, majority of the facilities are privately owned. And when we talk of the private facilities, this includes the pharmacies, the private drug shops, and the clinics. And shifting our attention to the second graph here, it indicates the availability of products in Bidibidi refugee settlement. And generally, there is a high availability of pregnancy test strips, Depo-Provera, DMP-ASC, and DMP-ASC provider administered. However, the graph shows gaps in the availability of emergency contraceptives and the DMPA, which is self-administered, and POP and COCs. Next graph, please. Next slide. So shifting our attention to the availability in Parabek refugee settlement, generally there is a lower availability if we compare it to the previous graph in Bidibidi. And the graph also shows low availability of male condoms, low availability of DMP-ASC, and POP and female condoms. However, in both graphs, I want to bring to your attention the high availability of Depo-Provera, and this can be leveraged on to promote self-injection with DMPA to promote self-care. Next slide, please. Okay, and this graph shows the average unit cost of SMC products in private facilities in both settlements. So the analysis of cost of products from this graph sheds light on the affordability of the self-managed products by the refugee girls. For example, the average cost of emergency contraceptives is 4,958 Ugandan shillings, and this is equivalent to $1.5. So if we picture this in the context of a typical refugee girl who totally depends on donations, and she doesn't even earn $1 in a month or even in a year. So will she be able to afford the cost of this product? Of course, no. So generally, the cost of the self-managed products was really on a higher note. Next slide, please. So based on the above findings, from the analysis of the findings, it showed that there was capacity gaps in commodity management. For example, we saw that most of the facilities did not have some of the products because of the procurement and ordering gaps, and therefore we recommend site level capacity building to improve projection, ordering, and stock management in order to increase supply reliability, which greatly shapes demand of these products. And also in some of the facilities we assessed, they had only one type of self-managed product, and therefore we recommend availability of a variety of products and associated supplies like blood pressure monitors and weighing scales, teaching aids. This should be available at all service points to meet the client's demand and ensure quality. And then in regards to the cost, we recommend partnership with private facilities to subsidize the cost of these products and also monitor the quality of SMC services in order to increase accessibility, affordability, and consistency of use. And finally, minimizing contraceptive prescription requirements is critical to empowering girls and reducing stigma, to improve uptake, to promote self-care, as some of the facilities still demanded a prescription before giving family planning products. Next slide, please. Yes, we are working together to make the improvement in self-managed contraception. Thank you so much for listening to me.
Thank you. Chair. Thank you so much, Juliet. Really appreciate it. And your presentation really highlights the importance of access to contraceptive options, including in refugee settlement settings, and the importance that also private sector plays in those areas. So thank you so much for that really interesting presentation. I'm going to move on to our speaker number 4, and right after this presentation, we'll go into a short Q&A. But before that, Laura Nabwire is the Kenya practice lead at In Supply Health, and she has over 18 years of experience leading regional commercial supply chain solutions and managing projects across the private sector, which includes pharmaceutical and consumer health, public and nonprofit sectors, with a total market approach in order to improve access to quality health products and services. Over to you, Laura.
Thank you, and good day, everyone. Thank you so much for making time to join us in this presentation. The World Health Organization advocates for task sharing and pharmacist empowerment in providing sexual and reproductive health services. In Kenya, the Ministry of Health has updated the National Family Planning Guidelines for service providers, authorizing pharmacists and pharmaceutical technologists to offer short-term contraceptive methods, including DMPA-SC for self-injection. The pharmacy channel in Kenya is the first contact for primary health and self-care, but it does not offer expanded family planning methods like DMPSC. Pharmacies are primary source of oral contraceptives, emergency contraceptives, and condoms in some Kenyan towns, but only 6% of injectables. For the work that we are doing in supply is investigating how we can be able to improve access to quality contraception and self-care by exploring the viability of private pharmacies, stocking and selling DMPSC for self-injection. Next slide, please. We are in Supply Health. We're an East African health advisory firm, wholly owned subsidiary of JSI, and we're pioneering innovative approaches on this side. Our domain expertise areas include supply chain, monitoring, learning and evaluation, market development, and capacity building. Next slide, please. These are the objectives, the goal and the primary objectives of our project. So we are doing an implementation research across 27 pharmacies to explore and test viability and scalability of a business model that offers customers convenient, discrete, quality family planning. And some of the objectives we seek to see is there an increase in the number of women accessing quality FP? Can we document value proposition for pharmacies? Does it make sense for them? Ultimately, can we scale up? Now, the geographical clusters that we picked are in diverse areas and identified as growing hubs for the middle class populations. We used mixed method design, data collection, included monthly sales data, client exit interviews, and key informant interviews with the pharmacy personnel. Next slide, please. Thank you. Now, phase one was about HCD, always starting to walk a mile in the user's shoes. And we are now in phase two, where we are testing some of the solutions that we realized from phase one into phase two. In this case, 27 pharmacies across 3 geographic areas in Kenya. We have 47 counties. We are working in 10 of them. And we are working to see if then we can scale up the solutions that we are seeing and the results that we are seeing. Next slide, please. We implemented solutions that were inspired by the HCD work done in phase one. Some of those that we're implementing is customer retention. And we've seen pharmacies using some TCI cards, callback cards, reminder cards, WhatsApp, to see if we can really communicate the messages that we need. The pharmacies are doing this. Pharmacy mentorship, always passing it on so that more than one provider, the pharmacy, can offer DMPA-SC and injectable contraceptives as part of a wider family planning mix in pharmacy, safe spaces for confidentiality, checking of other vitals, and as well as branding, demand awareness, demand creation, which we've seen to be real conversation starters in this section. What are some of the results we are seeing? Next slide, please. So, for the pharmacies, we have noted that between January and June 2023, the participating pharmacies were able to see over 5,000 new and over 8,000 repeat clients. Even when we had a bit of an issue with DMPAC product availability, and we are working on this, then the awareness got better as we got more clients knowing about DMPASC. Next slide, please. Now, on the client side, do clients feel confident accessing product in pharmacy? We noted that regardless of price, most pharmacy clients prefer purchasing family planning from pharmacies for convenience. So client demand, product availability, and profit margins determine to the pharmacy what is stocked. While there are secondary contributing factors such as provider preference and bias, we have seen that more clients are choosing to access for those who are willing and able to pay. So convenience is the primary reason that they're accessing product in pharmacy, while 90% of those surveyed actually indicated that they're satisfied with the service that they're receiving in the pharmacy. Next slide, please. The Kenyan Ministry of Health has recognized the importance of a total market approach and the role the private sector is playing in increasing access to uptake of contraceptives and meeting some of the goals that we have as a country. And pharmacies are able to free up public sector resources and expand access to family planning and self-care by offering discreet and convenient options. Now, in that regard, the key policy milestones for FP in pharmacy have been led by the Ministry of Health, and it is on these that we are basing our work in market test. Our next steps on market test include ensuring that we work on the supply chain pipeline by some of the initiatives already led by the Ministry of Health, public-private partnerships to check on the supply, a total market approach task force, as well as public-private sector engagement on the supply chain, pharmacy linkage, and having a self-care core group. Please read more about the work that we are doing and contact myself or someone at InSupply Health to get more information on this. Good day, everyone.
Thank you so much, Laura. This was such an interesting presentation because it included some human-centered design work to inform the solutions and keeping users at the center of the work, and some really interesting results, especially as it relates to client experience around convenience and client satisfaction. And I love the point that you made at the end about how these solutions are starting to inform decisions that are happening at the national level. And so really, really interesting work. All right, that concludes the first set of speakers. We've concluded the first 4 presentations. We now have just under 10 minutes of Q&A time. And there were several questions that came through the chat. Please continue to submit them through the chat. I'll do my best. Fauzia, I saw that you answered 2 questions in response via the chat. So thank you for that. I'm gonna take the first question that came through for Ijeoma from Gilda. And the question, Ijeoma from Gilda, was how long does the training of pharmacists and CHWs on the self-care absorption, how long does the training last? Do you mind coming off of mute and addressing Gilda's question?
Okay, thank you for that question. These trainings are done twice within weeks with refresher trainings and work progress discussions, as it covers like broad SRHR topics needed for abortion provision within restrictive context. So after when we do these trainings, like within 16 hours a day, we do it twice within weeks, and then we follow up with connections and communications in case there are further questions that they need, or work progress discussions.
Excellent. Thank you so much, Ijeoma. All right. The next question, I am going to direct it to Juliet from IRC. And Taban asked this question, which was around, why do you think access to SMC from government facilities is low compared to the NGO and private facilities at the settlements in Uganda where you conducted the work?
Thank you so much, Chair. The access is low, as I mentioned earlier, that are because of the facility-based barriers, which include the distances. We know that Bidi, for example, is the second largest refugee settlement in the world. So the distances are really big. And then we have the issue of the language barrier. So most of the facilities are having Ugandan healthcare providers, whereas the refugees are from South Sudan. So there is that issue of the language gap, whereas the folks in the private facilities are South Sudanese, and therefore they can attend to the demands of the girls. And then at the facilities, we have privacy concerns, where if a young girl came in to ask for family planning, she's actually revealing that she's having sex. So, and therefore, the private or the private facilities provide that privacy. And also, in addition to other barriers like the understaffing and the long waiting lines. So the access is more in the private facilities. Thank you.
Thank you, Juliet, for that clarification. Yasmin, thank you for responding to Mary's question in the chat. I'm going to direct the next question to Laura, which came through from Soumya. So as pharmacy provision of self-care products increases, it'll be useful to know if the pharmacies provide the full range of self-care products like male or female condoms, self-injection, pills including emergency contraceptive, and medical abortion products. Relatedly, are there particular products that pharmacies wish to stock and sell?
Thank you. That's a really good question. So as part of the data that we collect, we developed what we're calling a tally sheet, because our project is centered, yes, around self-care and DMPC for self-injection, but also as part of a larger basket of self-care product, emergency contraceptives, pregnancy tests, HIV self-testing kits, as well as male, female condoms, oral contraceptive pills, and even the opportunity to refer for longer acting methods. So yes, our pharmacies are stocking these. What is happening is that using the medical eligibility criteria that the pharmacies are trained on, then they are able to advise the client on which method is best. If it's available and they are able to give it safely, then they get it at pharmacy, or the clients are referred elsewhere. Any other products pharmacies would like to stock? They'd like to stock implants and, get trained on how to insert and remove, as well as get steady supply of product. So we do have other self-care products that are being offered in the pharmacy.
Thank you, Laura, for adding that extra context and color to the work that you're doing. And I know that there are several questions coming into the chat. I'm going to ask one last one to you, Laura, before we move on to the next set of speakers. And this last question is from Kristen. Can you share where the partnering pharmacies are located in Kenya? For instance, is it in an urban environment? And is the work focused on large chain pharmacies, or does it also include the smaller independent pharmacies as well?
That's a great question. Now, what we did during the HCD phase, we actually developed some pharmacy archetypes, meaning what type of pharmacy is likely to stock this product, what kind of clients are likely to go there, because part of our co-designers were clients and actual pharmacists, pharmaceutical technologists, pharmacy owners or providers. The pharmacies we have are a wide range of pharmacies. Some in rural, we have 26 pharmacies, some in rural settings, semi-rural, some next to health facilities, others next to universities, others very urban. And out of chain pharmacies, we have 2 out of a chain of pharmacies that has approximately 100, 200 outlets. So we have a mix of pharmacies. So the results we are getting are nicely varied, which is going to inform scale up, which solutions work in which case. And we're realizing that there's many archetypes as their individual pharmacies, understanding that these are individual businesses. And yet there's so much opportunity to scale up once, we twiddle and ensure that we are taking care of some of the areas like supply chain, access to product, demand generation, more training for the pharmacies. So we have a wide range of pharmacies. And please, Kirsten, we can always have a discussion on the side for you to see the kind of pharmacies we are working in.
Thank you so much, Laura. Excellent additional context there. There were 2 more questions in the chat, one from Lemshep and then another one from Joanna. I might ask Laura if you and maybe Yasmin from the InSupply team can answer those questions directly into the Zoom chat. So we can actually proceed on to the next set of speakers and presenters. But a really, really good engagement from our audience. Thank you so much. Please keep the questions coming to the first set of our speakers, and hopefully our speakers can respond in the Zoom chat. All right, if we could move on to the next slide, so we could pull up our next speaker who's going to be sharing with us today. Our next speaker is Bikalu Mosi, who is a Senior Research and Evaluation Advisor for IPAS Ethiopia. He received his MBA in Measurement and Evaluation from Addis Ababa University and holds 2 bachelor degrees in Statistics and Marketing Management. Bikalu has been conducting research on sexual reproductive health and rights in Ethiopia for the past 9 years. At IPASS, he has led various research and evaluation projects exploring provision of person-centered abortion care in public health facilities of Ethiopia, the impact of COVID-19 response on SRHR services, and the impact of community-based interventions on abortion knowledge, stigma, among other things. So with that, Bikalu, I will hand it over to you.
Thanks, Bhavya, for the nice introduction. My connection is unstable, so I will stay in audio mode. Sorry for that. So, hi everyone. Today I will be presenting lessons from abortion self-care pilot program implemented through pharmacies into Ethiopian cities. Next slide, please. So, evidence. Okay. So, as you know, evidence that suggests that abortion self-care is on the rise globally, and the same is true in Ethiopia. According to some studies and the findings of our rapid assessment from 41 private pharmacies, significant number of women are visiting private pharmacies to obtain information and counseling on how to end their unwanted pregnancies. Most of them procured MA drugs and took it at their home to terminate their pregnancies. Pharmacists from our rapid assessment estimated that on average 10 women visited a pharmacy per month for medication abortion. The number ranges from 5 to 25. On the other hand, the advent of medication abortion as a method of pregnancy termination appears to have a positive association with the the gradual rise of PAC cases over time. This is because providers from pharmacies and some private clinics do not have the necessary knowledge and the skills to administer or to deal with self-managed medication abortion. As you can see from the graph in the right-hand side, the service data from IPASS supported health facilities clearly demonstrates the drop in safe-induced abortion coverage and the progressive increase in PAC cases over time. You can see that the proportion of PAC cases increased from 17% in 2003 to 50%, 50, in 2023. Basing this evidence, IPASS Ethiopia developed a harm reduction pilot intervention that addresses the gaps seen while administering medication abortion at private pharmacies. Next slide, please. Next slide. Okay. So the pilot program implemented in Oromia region, specifically in Adama and Shashamane cities from December 2021 to April 2023. 41 private pharmacies were selected for the intervention and received training and supply chain support, to sell medication abortion pills without prescriptions, and counsel consumers on self-managed abortion. Pharmacists were trained to administer MA drugs with compassionate care. They trained to use HSPR and Safe Abortion app to assess gestational age and access reference materials. We also trained them on VCAT, value clarification and attitude transformation, as well as post-abortion contraception. They also distributed flyers in local languages detailing expected symptoms and danger signs for consumers. The program was monitored and evaluated, through pharmacy logbooks, supportive supervision visits, and after 21-day follow-up surveys with women who purchased, MA drugs. When we see the outcome, a total of close to 1,500 women received MA services during the pilot period from these supported pharmacies, and more than 1,200 or 85% were followed up. They were in follow-up call after 3 weeks. During the follow-up call, 98% of the cases or women reported that they had a complete abortion, and only 4 clients reported signs of complication. Next slide, please. So this is, a quote from a participating pharmacist. He said that my participation in this program helped me completely to change my previous attitude for safe abortion care. It has changed not only my attitude, but also my social relationship with clients and community members. 3 years ago, I had decided to sell and secure MA drugs in my pharmacy. However, it was expired on my hand while waiting clients with prescriptions. Since then, I decided not to have the drugs in the list of drugs, but nowadays, I'm proud of the feedbacks and respects that I am getting from my clients. And, I will continue supporting the women facing this problem. So this is one of the quotes from the participating pharmacists. Next slide, please. So the big lesson from this pilot intervention is that pharmacies are at the forefront of self-care, and if they supported adequately, they can improve access to safe abortion services and bring the service closer to women and girls. The pilot intervention was not implemented without challenge. One of which was, there was inadequate legal and structural framework to support, abortion self-care, and some pharmacists, because of this, some pharmacists were in fear of legal risks or accountabilities. The other one is, there was frequent stock out of MA drugs and procurement difficulties. Also, there was pharmacist turnover and abortion stigma from the community. And the last one is, there was weak public-private partnerships to refer to cases to public health facilities when needed. Next slide, please. Yeah, that's all from me. Thank you so much.
Thank you so much, Bukalu. Really interesting work that you've been leading in Ethiopia. And the thing that you mentioned the last has stuck with me around pharmacists are at the front lines, and how do we as a community continue to support them with the training, knowledge, and tools that they need in order to provide women with the services. So thank you so much for sharing those learnings with us today. Our next speaker is Olawale Dorosimi Eti, who is the country lead for JSI Research and Training Institute for the Nigeria office. And he also serves as the chief of party for the Total Market Approach to HIV Prevention project that is funded by USAID in Nigeria, where he provides technical and administrative leadership to the Nigeria team to improve the sustainability of HIV prevention programming. He has over 17 years of public health experience working in public and private sector healthcare services. Olawale holds a doctorate of public health degree from the University of North Carolina at Chapel Hill, and also an MPH from the University of Liverpool in the UK. Olawale, thank you so much for being here. Turning it over to you.
Thank you so much. Hello, everyone. It's really my pleasure to be part of this presentation today. Today, I'll be sharing with you some of the activities we are currently implementing to increase access to HIV self-testing in the private sector in Nigeria. And I'm making this presentation on behalf of the team who have been doing this work over the years. Next slide, please. So some bit of background. Next slide, please. In 2019, as part of effort by the government of Nigeria to increase HIV testing uptake and to capture the otherwise undiagnosed cases of HIV in Nigeria, the country adopted HIV self-testing as part of its priority policy and programmatic approaches. Despite these steps, we observed that access to and uptake of HIV self-testing remained very slow and very low, especially in the private sector. Next slide. With funding from USAID for the total market approach to HIV prevention programming in Nigeria, we came up with a number of strategies to increase the use of HIV self-test kits and other prevention commodities among KPs. These are the key population groups and the general population, and also conduct a number of activities to facilitate the private sector engagement and to strengthen public-private partnership, which were all aimed at increasing access and uptake of HIV test kits in Nigeria. Next slide. So because we were aware that solving this problem of access to HIV self-testing cannot be solved with just one intervention, we came up with a number of interventions, about 6 of them in all. The first activity was to conduct a retail market assessment of the HIV test kit market in Nigeria. And from this assessment, we were able to identify and map unvalidated HIV test kits in Nigeria. Next, we conducted and facilitated dialogue with key stakeholders to understand and document barriers around awareness, pricing, and availability of validated HIV test kits in Nigeria. With this information, we engage with the regulatory authorities, the NAFDAC, using evidence from the stakeholders dialogue, and ensure that this agency understand what the challenges are around the availability of the commodities. With the conversation, we're able to support 3 marketers of HIV test kit brands in Nigeria to navigate around the challenges and bottlenecks around product validation and registration in Nigeria. Next. In addition to this, we also collaborated with the Pharmacy Council of Nigeria to develop a curriculum and to train private healthcare providers, especially pharmacists in the private sector and the patent and proprietary medicine vendors, to ensure that they understand the importance of HIV self-testing and they can also market these products to clients who visit their outlets. In addition to this, we provided the trained personnel with high-EC materials that can be displayed across their outlets to create awareness for HIV self-testing and the kits availability at the outlets. We also, after the training, collated the directory of all the trained pharmacies and the PPMVs and uploaded them on the project website. We have a website where, in addition to all these activities, we run a demand creation and awareness creation campaign called the KISS campaign. And on this website, we uploaded the directory of these trained pharmacies to provide information to the general public on outlets where HIV self-test kit can readily be accessed. In addition to this, we also engage with HIV self-test kit brands in Nigeria who have the market authorization for the products to negotiate with them cost-effective pricing, because we understood that pricing was one of the greatest barriers to accessing HIV self-test kits in Nigeria. And then we were able to link the trained pharmacies and PPMVs to this market authorization holder to ensure that they could leverage the marketing packages that were available in terms of discounts and also lower prices for these commodities. Finally, we created a WhatsApp group where all the key stakeholders, including the pharmacies and the patent medicine vendors, were part of the WhatsApp group for us to be able to provide continuous monitoring and follow up and to be able to answer questions that these healthcare providers may have to ensure that they can provide these services effectively to the general public. Next. So in terms of the results, following our intervention, we were able to support the validation of 3 new blood-based brands of HIV self-test kits in Nigeria. And as at the end of 2022, we were able to have a total of 5 validated and registered HIV test kits in Nigeria. Secondly, we were also able to work with the Pharmacy Council of Nigeria to ensure that HIV self-test kits is included in the approved list of commodities that PPMVs will sell to the general public, because we know that these are highly regulated cadre of healthcare facilities, and they have a limited number of commodities that they can actually handle, and other pharmaceutical devices. So we work with them to ensure that HIV self-test kit was included on this list to ensure that they align with the regulatory requirement for the products. Thirdly, we were able to also work with other stakeholders to ensure that the average monthly sales of HIV test kits, which stood around less than 4,000 monthly in the year 2020 to over 10,760 at the end of 2022. In specific terms, we were able to increase the sales of HIV test kits from less than 50,000 in the year 2019 to about 96,000 in the year 2021, and about 129,000 at the end of 2022. And then finally, we also were able to negotiate the pricing for HIV test kits, which stood around 3,500 Naira per kit as at 2020 to around 700 Naira per kit at the end of year 2022. Next, please. So I'll conclude by saying that the strategic private sector engagements and collaboration, which we facilitated with relevant partners, contributed significantly to the increase in the availability and access to validated HIV self-test kits. And as a project being implemented by GSI, we will continue to leverage on this multi-sectoral coordination to ensure that we expand the capacity building for community pharmacies and PPMVs and encourage them to stock HIV self-test kits. We will also continue to work with other implementing partners in Nigeria to negotiate with marketers for effective pricing of these test kits and ensure that we are able to support new brands to come into the market to create healthy competition, which we believe will also help to reduce prices for the commodities in Nigeria. And finally, we will continue to use social media platforms and other platforms to create demand for HIV self-test kits and ensure that the general population, and especially the key population groups, are aware of the benefits of using HIV self-test kits in Nigeria. Thank you.
Thank you so much, Olawale. Really interesting work. I love that we had an HIV self-testing presentation, and you hit on some interesting themes related to the importance of price and policy changes in terms of getting HIV self-test on the commodities list for PPMVs. So a lot of different perspectives to this conversation that we're having today. So thank you so much for sharing those learnings and insights with the group. I'm going to move us on to our final speaker, last but definitely not least. Simeon Christian is a monitoring, evaluation, research, and learning advisor for Society for Family Health. He has been part of the teams that are championing the self-care movement in Nigeria through the DISC project, which seeks to give women the autonomy to determine their reproductive health destiny. He will be presenting his work with stakeholders and how this translates into the self-care movement. Simeon, over to you.
Thank you very much. Good afternoon, everyone, and thanks for joining. My name is Simeon Christian Chiku. It's my pleasure to present the work that we've been doing under this project, under the Society for Family Health, within the last 4 years. But I'd like to also acknowledge very quickly the support of my program assistant, Ms. Adedoyin Oluwakemi, who supported this process. Next slide, please. Thank you. So the DISC project is a 5-year project funded by the Children Investment Fund Foundation. Essentially, it supports and gives women the autonomy to be able to decide or to be able to take charge of their own reproductive health destinies. And this project currently works with Society for Family Health in partnership with PSI, Population Service International in Uganda, and actually supports women to demand and access self-injection as part of a comprehensive basket of contraceptive options. And so currently in Nigeria, this project operates in 15 states and then in 3 countries in Africa. Next slide, please. Okay, so essentially we aim to demonstrate that self-care, beginning with contraceptive self-injection, is a viable cornerstone of sexual and reproductive health care, and by offering women increased voice, choice, and agency over their self-care, offers them help, improves the health systems, and gives the health system a new and critical partner, that's the consumers themselves. Next slide. Okay, so before I go into the approach and the settings, I'd just like to give a few brief background or an introduction. We all know, or you agree with me, that one-off trainings are often not enough in winning healthcare providers into the self-care behavior. And there is need for continuous supportive supervision and mentorship. Of course, because we know that these healthcare providers have been used to the provider-administered approach for over the years, and then bringing in the self-care behavior. And so, so from the inception of a project and throughout its implementation cycle, it's always important to keep thinking about, the sustainability phase of every project. And that's why the DISC project has found it very interesting to use the supportive supervision and data quality assessment as a means of sustaining the self-care movement and approach in Nigeria. Next slide, please. Okay, so now for the approach, the supportive supervision. No, please go back to the last slide. Thank you. Yeah, so supportive supervision is an approach that is adopted to assist healthcare workers in enhancing their work performance, and also to be able to offer quality services and promote mentorship. It has been implemented to improve routine program monitoring and evaluation. So these stakeholders that we keep talking about actually comprises of the state family planning coordinators. We also have the state M&E officers because they support the data reporting system and processes. And then we have the LGA monitoring and evaluation officers who are also charged with the responsibilities of ensuring that the data generated from the facilities where we support trickles down into the national instance. And so the state officials, through the supportive supervisions, facilitate the promotion of self-care by monitoring the quality of care in the project intervention facilities, and then providing, of course, on-the-ground support to healthcare providers, and of course, escalating problems faced at the state level to the project. They also serve as a midwife between the project and the state in terms of promoting and domesticating the culture of self-care for health workers. So these stakeholders often hold what we call a routine quarterly review meetings to discuss some of their findings, some of their challenges, and then also fashion better ways of promoting self-care across the state. Because the DISC project is also limited in terms of the number of facilities or in terms of its scope, these stakeholders often help to cascade catalytically this impact to other facilities that the DISC project does not directly support. And you will be marveled at the results that we have seen. Next slide, please. Thank you very much. So between the month of April, we actually rolled out the SSV, which was adapted from the National Integrated Supportive Supervision Checklist. We rolled it out in the month of February and then started piloting, but formally rolled it over to the state in the month of March, and then they began to use this to conduct supportive supervisions to the facilities. And so between the month of April to September, which was a 6-month period, the stakeholders have been able to conduct at least 1,605 data quality assessments to these facilities. I will explain in a nutshell why they do the data quality assessment. And then also within the same period, they have been able to conduct 2,891 supportive supervisions across the 15 states. You could see the graphs. And then the graph on the right also shows the impact of these two work streams that stakeholders have been doing. It has translated into improved reporting rates for the project. You could see from the blue graph shows the reporting rate for self-inject, while the green graph shows the total number of DMPSC that the facilities provide, which means that the culture of self-care is actually gradually being embraced fully by the healthcare providers, even at the primary healthcare centers. And so essentially why they do the data quality assessment is because all of the works that we do needs to be documented and reported. So when these monitoring and evaluation officers are on a monthly basis, the results that the facilities generate are often taken to the LGAs for upload into the national instance. So each facility has the responsibility of submitting this data. So when on a monthly basis, a particular facility or a particular region is not submitting their data, or even when there are discrepancies in the data, it's always during this data quality assessment that some of these challenges are often discovered and then addressed on the spot. Next slide, please.
And Simeon, if you're able to wrap up shortly, that'd be great since we're at time. Thank you.
Yes, thank you very much. So we found that the state-led supportive supervision and DQA is a very effective means of strengthening healthcare system and enforcing the use of self-inject among women. And we also greatly recommend for other self-care projects or self-care advancement programs in Nigeria, because we've also found and seen that the future of healthcare is self-care. Thank you very much.
Wonderful, excellent presentation and learnings from Simeon about self-care and the DISC project in Nigeria. Thank you so much, Simeon, for sharing with us today. This now concludes the presentations from our wonderful 7 speakers today. We have some questions coming through into the chat. Thank you to continue for our audience members and our participants to continue to submit questions through the chat. Soumya, I've really loved your virtual participation. Olawale, I know that you responded to Soumya's question, but do you want to come off of mute and add additional context to Soumya's question that came through into the chat? And maybe before I ask you to respond, I'm going to voice over her question so everybody is up to speed. So based on your experience with the TMA approach, can you comment on if the private sector would have stepped into the self-test market without the market priming that your project provided? You know, in general, what's required for the private sector to step up on their own, especially as we move into an era of reduced donor support? Excellent question. And Olawale, feel free to respond.
Thank you. And absolutely, I agree. That's an excellent question. From my first response there, in fact, these HIV self-test kits were available in the private sector in Nigeria, even before the government, through the Ministry of Health, adoption of the use of HIV self-test kits as a key approach to solving some of the challenges around case finding. However, most of these products that were available at that point were not validated and registered by the regulatory agencies. And the reason for this, based on our engagements with the distributors, was that the use of HIV self-test kits is not really a viable market, and they were not really willing to invest a lot of resources because they felt that government and the donors were already saturating the private and the public facilities with HIV testing. And so there is no incentive for people to go to the private sector to screen for HIV. And so we were able to use data working with other implementing partners to show the existing gap between the target for HIV screening in Nigeria and where we are. We were also able to use data from other studies that have been done in terms of some individuals like men who are usually not willing to go to public facilities and would rather go to private sector healthcare providers like pharmacies, where they can easily be tested or do the test in the comfort of their home without anybody being privy to the result. While the intervention we've provided has helped, I think the market was already like gaining traction. We were just able to help them to see some of the gaps and to encourage them to continue to invest. Thank you.
Thank you so much, Olawale, for providing that additional context around the HIV self-testing space in Nigeria. We can probably take one or two questions. So participants and attendees, please don't hold back. So feel free to share additional questions for Bikalu, Olawale, or Simeon in the chat. In the meantime, I am going to ask for Molly to share the link to join the Self-Care Trailblazings group. I think that was something that came up at the beginning, so you'll also see a link to that come through in the chat. And the WRA team would also like to hear from you all. So there's also going to be a link to a survey to provide feedback on this session and an evaluation. So you're going to see those links come through in the chat. I see them there. Thank you, Molly. So if you all are interested in becoming a member of the Self-Care Trailblazer group, please fill out the registration form. And the team would also love to gather your feedback through a survey. So please also you fill out those links and surveys as you find appropriate. So are there any other remaining questions for our speakers today before we wrap up? Provide another 30 seconds for any remaining questions to come through to the chat. See. Any questions? This has been a really interesting 90 minutes for myself. I always learn so much attending these types of webinars and sessions. And there's been such a diversity of perspectives and learnings and insights that's been shared from each of our speakers. And so I have found it a very useful way to spend my morning, and hopefully you all have too. All right, I am not seeing any more questions come through via the chat this morning. So I will begin to wrap us up to say, first and foremost, thank you so much to the 50+ participants that joined us this morning. I hope that this has been a great use of your time and you've been able to take away some interesting insights and learnings. And I would also encourage, if you have more questions for our speakers, to reach out to them directly. This conversation doesn't need to stop today. And so really just encourage additional follow-up to happen offline to ensure that there are good connections and takeaways today. I would like to thank our interpreters. I know that you all have been hard at work behind the scenes to undertake a lot of quick translation and interpretation. This type of event wouldn't be possible without your support throughout. So thank you to our interpreters. I'd also like to thank our presenters. I know that 6 minutes isn't a lot of time to be able to share a wealth of information that's happening from your projects and your work. So thank you for doing your best to distill your learnings into a quick 6-minute flash presentation. If I can get some reactions from our participants who are logged in with either a heart or thumbs up or cheer as a way to show some appreciation to our presenters, I think that that would be immensely appreciated. And last but not least, I want to thank the back end team, our WRA team, Molly, Marette, so many others that went into not only just pulling this session off in real time, but there's a lot of planning that went into supporting the group to be able to get to today. So wanted to thank everyone and express our gratitude to that. And again, I think that's all that we have planned. So please feel free again to share additional feedback via the surveys. Feel free to sign up for the Trailblazer group via the links that are in the chat. And again, just want to thank the participants, the hosts, as well as the wonderful engagement that we've had today. I believe that there are additional sessions, and so feel free to go back to the Self-Care Trailblazers group to see additional sessions that you might want to join. Thank you all so much. Wish you all a great morning, afternoon, or evening, wherever in the world you are, and really, really looking forward to continuing this great work together. Thank you so much, and take care. Bye-bye.